Shall we start with the introduction?
Yochai, I think you can start directly.
Okay.
You are the chairperson.
Okay, so good morning or good day for everybody that is here. I see that only one of the discussants are here, but I think we can do it. And welcome. And it should be non-formal. And the idea is actually is not to find the truth, but the thinking process, how to analyze those ECGs. And I must say that there is a little bit different thought process when you start as an electrophysiologist, that you start with a pacemaker interrogation, or where you start as electrocardiographer, that you see a weird ECG. Not always you know, or most of the time you even don't know what is a pacemaker, what manufacturer, is it a defibrillator, biventricular pacemaker, nothing. And the programming parameters. So I would like to start with introduction. Do you see my screen?
Yes, we do.
Okay. So in addition, when we start reading ECGs, we have to look first, what is the atrial rhythm? Is it followed by QRS? When we are doing pacemaker, we have additional factors that, in addition to the PQRS, we have, if we have atrial pacing, we know that there is the AV delay until the ventricular pacing or the spontaneous ventricular contraction. After the atrial pacing, there is a programmed ventricular blanking period, because we don't want that the ventricular lead will sense activity in the atrium, think that there is ventricular activation. Therefore, the pacemaker, hi Henry, good morning. The pacemaker is not responding, is not recording. It can create a problem, as we'll see later. Post-ventricular activation refractory period that occur, in which after the ventricular activation, the pacemaker will do nothing in this period. So, and after the ventricular activation, there is atrial blanking, because again, we don't want that the atrial lead will think that there is atrial activation reading the ventricular activation. So we'll start a very simple ECG. It's a pacemaker. Can someone say what do we see here?
Yochai, I think the other speakers are also online. May I kindly ask them to turn on their cameras? I can see only the Ozge here, yeah. But others.
Henry Huang is also here, but we don't see him. Henry?
Yes, I'm here.
Yeah, okay. So Henry, do you want to start? It's simple.
Yeah, so this one, I always look at the ECG, all of the leads, look at the baseline, what's happening during the systolic and diastolic periods of the heart. Looking at the QRS, there's a large spike that is there. Looking at the morphology, looking at V1, it's a right bundleoid morphology, but the pacing spike suggests that there is pacing occurring, probably from a biventricular device. Looking at the sort of baseline of the ECG, I don't see a clear P wave, and I don't see an atrial spike. And I notice also that, the rate of pacing is relatively regular at 70. which seems sort of like an artificial cutoff. I suspect that, this patient is either in atrial standstill or in atrial fibrillation with very fine P waves, probably has mode switched and is pacing at this interval.
Yeah. So this is a very common problem, and you see up there that the Muse interpretation of the ECG is electronic ventricular pacemaker. No further interpretation, and indeed, a lot of esteemed readers do not go for the atrial activity. And this is either, as Henry said, either atrial fibrillation or atrial standstill, but it should be commented when you interpret. When I was a student, they asked us, what is atrial fibrillation with regular heart rate? And we had to say atrial flutter or digoxin toxicity. Now the most common cause is atrial fibrillation with electronic ventricular pacing. It is very common. And remember, if you don't comment on it when you interpret the ECG, it may take time until the clinician will realize that the patient has atrial fibrillation with the risk of stroke. It may take time to start anticoagulation and so forth. So this is ECG. Any comments from the audience? No. Okay, move on. So this is, again, a patient, 43-year-old male with non-ischemic cardiomyopathy with LVAD and biventricular Medtronic ICD. Here, I think we see the flutter wave, is the fibrillation wave. It is clear that it is atrial fibrillation. We need to make a comment on it. So 72-year-old male with ischemic cardiomyopathy, hypertension, chronic kidney disease, Medtronic biventricular ICD, routine patient, outpatient visit. What do we see here?
Can I make a comment?
Yeah, follow.
Okay, thank you. And first of all, as Mr. Huang said, we have to check the baseline rhythm and what is going on with ECG here. And as it's written, there's biventricular ICD, but yes, we see big spikes, and after we see pacing that contributes to QRS contributes to the ventricular pacing. But I'd like to point out, just as the ventricular based, this seems to be biventricular, but the QRS is not narrow enough, I think, and as we don't see R waves, the dominant R waves in lead V1, and there is not enough negativity in lead 1, so the QRS is positive in lead 1. So I think the LV contribution is less here. I think the biventricular is not functioning enough, the pace. So, and when we see, as you said, the P waves are very irregular and the heart rate is irregular. And we also see premature ventricular complexes and with pace spikes on the peak of it. So it seems to be also, they are not sensed, they are not the atrial pacing events, but no, I think it's just we see the irregular P waves and irregular ventricular rhythm and less LV contribution of the biventricular pacing. But I also see that this ventricular event is not sensed and there is a pace spike on it just for beginning.
So what do you think? Is it well, probably there is left ventricular lead malfunction and irregular baseline atrial, probably atrial fibrillation. But what are the pacing spikes on top of the QRS? Is it pacemaker malfunction under sensing, or is it normal response of the ventricle?
Actually, we should evaluate the PVC where it arises. Maybe we can evaluate this, because when we see the inferior leads, like the leads D2 through the lead AVF, they are positive, and actually in lead V1 they are, I think they really arises from a ventricular place, from a myocard is really close to the RV lead. So they will just can't sense it because they just fell within the blanking period. So they can't inhibit the ventricular pacing. Yani, I have a comment like that. So I think it may not be a malfunction. It may just be because of the ventricular, the premature beat where it arises from. And
Okay, is Professor Gutiérrez here?
Yes,
Yeah, okay.
I am here. Thank you.
So do you have any comment on the pacing on the QRS in those PVCs or spontaneously conducted complexes?
Yes, I think in general, my commentary is the same as the other participant, but we cannot discard that the left ventricle lead have any kind of problem. Maybe this is just a matter of programming, so we cannot affirm that the LV lead is dysfunctioning. So further than this ECG evaluation, we will need to check with the programmer if effectively the LV lead is functioning.
Okay. And Henry, do you have any comment? Henry, are you?
Yeah, I'm there. I agree. It looks more like an RV septal pacing morphology. I'm looking at lead 3. On the bottom, you see sort of two spikes that are close together. I wonder if sort of they had offset the RV more, that would change the pacing morphology. But it's very curious. I agree for biventricular paced complex.
Yeah. What I wanted is the comment on the pacing on the spontaneously conducted complexes.
Yes, not necessarily. That spike that is appearing in the middle of this premature ventricular contraction do not necessarily means that there is a kind of problem. Some ectopic beats need to be checked or need to be sensed, but it depending its location, sometimes we can observe this phenomena and not to say that there is some problem.
Well, remember that biventricular pacemaker is programmed to maximize pacing. In contrast to RV pacing, will go there that there are algorithms to minimize pacing. So many times, this is the terminology is not exactly safety pacing. They want to synchronize. So when they start filling the QRS, they pace on top of it in order to synchronize it. Now, technically, you can't, because it's atrial fibrillation, you don't know if it is a native spontaneously conducted beat without pacing or PVC. We call it PVC because it is white, but we don't know. And at Texas Heart Institute, which all those ECG are coming here, we have a lot of patients with severe cardiomyopathy and bizarre ECGs. So Henry, how do you call it?
How do you call what?
This one. It sends and it wants to synchronize.
Yeah, it looks like it's about 80 milliseconds after the start of the QRS. So, I know that Boston has an algorithm where if it senses ventricular depolarization, we'll try to give an LV pace spike. And so I guess what you're invoking is that this is something similar.
Yeah, I think so. But the main issue here first is the atrial fibrillation. Don't miss, see the computerized interpretation, electronic ventricular pacemaker. There is a biventricular pacemaker that the immune system doesn't know about. But if you know that the patient has biventricular pacemaker and the complexes do not look like, you should alert that there is might be a problem. As you said, Professor Gutiérrez, either programming problem or lead problem. And this is probably a normal phenomenon and not related to lead malfunction. What do we see here? Someone wants to take? It's the same line.
It's the baseline rhythm. It looks like atrial flutter and with ventricular pacing, ventricular electronic pacing, but it has a. Let me check the VV intervals. So 5. The pacing almost occurs like 60 beats per minute. So I think it's not a tracking mode, because also we don't want the device to track the atrial flutter or fibrillation waves, so it will be harmful for the ventricle. So I think it functions in maybe DDI mode, so it goes constantly during the ventricular paces. And yeah, at first I can make this comment.
Yeah. As a reader, not knowing the program, all you can say is that there is atrial flutter, there is ventricular pacing that is regular, that the complexes don't look like right ventricular pacing. I mean, with the right axis here and probably right bundle branch lock in AVR, it's probably biventricular pacing, although you don't see clearly the biventricular pacing, but there is no RSR prime in V1 again. We are talking that we are doing biventricular pacing in people with very bizarre, abnormal baseline ECG, severe cardiomyopathies. So we hope that the biventricular pacing will narrow the QRS and make it almost normal or right bundle branch lock. Not always it happens.
Yochai, can I make a few comments on this ECG?
Yeah.
So, with the DDI mode, I completely agree. If you look in lead 3 and you track the relationship, I think, between the flutter wave and the QRS complexes, you see that it's isorhythmic. So if you look at the interval from the first flutter wave to the QRS to the next QRS complex, the flutter wave to the QRS is shorter. So telling you that it's independent of the atrial rate. And then you see the rates are regular. And, we see these with BIVs, this sort of negativity across the precordium. If you're right, if there is a cardiomyopathy, because if the heart is very spherical and dilated, it can give sort of an apical appearance in the precordial leads. And the other possibilities are placement of the branch, or if with something called left bundle or septal area pacing, which can be lower, you can sort of see this R prime in the middle of the QRS if it's not placed well, with this sort of transition in a larger heart.
Okay, so let's continue. A 79-year-old male with a history of atrial flutter underwent successful ablation of atrial flutter, dual chamber pacemaker placement, Medtronic, due to high degree AV block. And the ECG on post-op day 1 is obtained. It's a DDD with a lower rate limit of 60, upper tracing rate of 120, upper sensor rate of 130, AV delay 150. What do we see here? Anybody volunteering?
First of all, I think after the ablation, the P waves are visible on the baseline. Yes, and the first beat is, I think, again, it's a wider QRS, and it's different from the other beats. And I think it's really strange. The first spike looks like the atrial pacing spike, but it's really wide. I think it's a premature ventricular contraction again, but there is also in lead V5, there is also like another spike. Also, we see it on the third beat again. There are two spikes on the even numbered beats, and then the second beat is like there is an interesting activity. We see P wave, and it's followed by the QRS, but there is again a spike before the QRS, but it has an isoelectric period after that. So is it the intrinsic activity, I think? But on the other beats, we see, for example, here 1, 2, 3, 4, 5, 6. In the seventh beat, there is again two spikes, but after the first spike, we don't see an atrial capture. If I'm not wrong, yes, I think there is some atrial loss of capture, and just for the first, there are lots of premature ventricular contractions, and the first of all are the intrinsic activities, I think. The paced QRS morphology is, yes, left bundle branch block, so it's correctly paced. But before that, the atrial spike is, I think there is an atrial loss of capture here. If I don't miss the P wave, at the first comment, I see loss of capture, so there is a lead malfunction, and just for the first, I'm going to check out.
So let's say that it starts with a P. So there is some atrial activity that is regular, probably with complete AV block. These P waves are not conducted in AV dissociation. Now, there is a pacing, and probably, if you look at the distance, this and this and this and this are atrial pacing. So why do you have atrial pacing here after the P wave? It means that the right atrial lead doesn't sense the P wave. You have a problem. And I gave a clue 1 day after pacemaker implantation, where the lead can be dislodged. So now you have here atrial pacing and ventricular pacing, like here. But here are the atrial pacing that occur and after a P wave and should not happen and did not result in a P wave. But here the question is, what is this component? So we have two possibilities. One, that it is a spontaneous ventricular activation that occur in the blanking period of the computer, and therefore the computer, the pacemaker didn't detect it at all. And the other is the atrial lead is floating and sometimes is in the right atrium and doing nothing, and sometimes falls into the right ventricle and activates the ventricle. And after it, because the pacemaker is programmed not to sense activity, there is ventricular pacing. Any comments?
In this scenario, we usually see that spontaneously ventricular activity is sensed by the atrial lead, the functioning and atrial lead, and then the pacemaker runs the safety pacing algorithm. So when we check a couple of spikes very close between them, we can suspect that the pacemaker is running this algorithm.
Can you guys hear me?
Yes.
Sorry about that. I logged out. So I agree with you that it's, it looks like a lead has dislodged. I think with that first spike, when you see the two spikes that are close together, it's activating so quickly, and the atrial lead is probably crossing the tricuspid annulus. I think the atrial lead is pacing. It's not seeing atrial activity. And if you notice, the second spike is about 110 milliseconds from the first spike. It's probably trying to initiate safety pacing, because it senses something in that zone, and so the pacemaker's, probably doing that.
Either safety or simply it didn't recognize because it's a blanking period.
Yeah, but you could, if there's far field on the lead, which it's going to see because the atrial lead is in the ventricle, it will see far field, right? So it's going to see, the lead will see, although it's atrial, see a depolarization if it's sitting in the ventricle. If it sees depolarization after the blanking period, it will initiate this sort of safety pacing just in case, right? Because if you place a lead in and there's far field, the manufacturer doesn't want ventricular pacing to be inhibited by that. And so it will deliver sort of the second spike. That's what I think is going on. It's just so characteristic, that second spike, and you see the notches on the bottom, which are nice. And it's about 100 milliseconds after the first.
Okay, let's move on. A 79-year-old. Yes, this was dislodgement of the right atrial lead and all what we discussed. So this is a 79-year-old male with coronary artery disease, history of bypass, MACE procedure for atrial fibrillation, recurrent atrial fibrillation, Medtronic dual chamber pacemaker in 2010. What can we say here? I think it's quite simple. You have regular pacing, probably atria. At first, it look on the T wave, but atrial pacing on the T wave is not a problem, and very prolonged AV conduction. This is typical for Medtronic, called MVP. MVP not stands for mitral valve prolapse. It's minimizing ventricular pacing, if I think. This is the right ventricular pacing with an algorithm to minimize, so it gives a chance, and we program it if we know that the AV node is normal. So it gives a chance for the spontaneous ventricular pacing. Otherwise, it looks normal to me, but always it looks bizarre. I must say, I'm not putting pacemaker. I'm not an electrophysiologist. I have not seen a lot of MVP recently. Has it been abandoned? Do you know? Henry?
I don't think it's been abandoned, but it can maybe it happens more nocturnally now. I think because there can be issue or drop beats, because essentially it's hysteresis to prolong it.
Yeah.
I think more people are going to CRT if necessary, or doing ISE or left bundle. And, this manufacturer sort of supports that type of lead placement, but it's still around.
So this is a 78 years old male with coronary artery disease, again, bypassed, CAA, atrial fibrillation, ablation, Medtronic pacemaker. What do we see? If anybody wants to join, this is again probably MVP, very prolonged atrial pacing to spontaneous QRS. We don't see, here we see P wave in V1. Now, there are artifacts, but atrial pacing, prolonged AV conduction, QRS. Atrial pacing, prolonged AV conduction. Atrial pacing, no QRS. So now the MVP program calls one AV sequential pacing. AV sequential pacing, and give it a chance again. Atrial pacing, ventricular, spontaneous ventricular. Atrial pacing, and so forth. So, and might be an old inferior MI, which is, again, extra. But this is a normal function of the MVP program with a dropped QRS. Any comments? So 62-year-old woman with pacemaker implanted 2 months ago. It is a fresh ECG, last week. Henry? Any volunteer?
Very interesting tracing.
Yeah.
Our first hypothesis could be because we are looking at a spike in the ST segment, absolutely abnormal. Our first hypothesis could be that the QRS, the atrial lead is dislodged, and the QRS acts like a P wave, and then the ventricular spike. Of course, we will have capture because the spike is appearing in the ST segment.
This was a dislodgement of the LV lead, the RV lead, excuse me, RV lead. So this is a P wave, this is spontaneous QRS, and the pacemaker didn't sense it because it's in the blanking period. So now they are pacing on the ST, but the lead perforated. Unfortunately, the patient died last week from sepsis, AML, sepsis, and so forth. Any comment? So this is a very bad ECG. This is not normal when you see it. "61-year-old female with ischemic cardiomyopathy and Medtronic biventricular ICD in place." Henry, do you have any?
Can you hear me?
Yeah.
Okay. So this is a Bive ICD. Looking at the baseline, it appears like the patient is probably in in AFib. There are PACE QRS complexes, which are probably the narrower that are the intrinsic. In lead 2, you have a very narrow complex, then a PVC, and then sort of a third morphology, which might be fused. It looks like there are since this is AFib, they're not necessarily PVCs, but they could be naturally conducted beats, that are occurring. And then you see pacer spikes that are probably earlier than the lower rate interval. I guess this potentially could be another example of what you mentioned. It's just what's interesting is that the timing of the spike relative to the QRS is a little longer than the last example. Yeah. But again, it depends on sort of intrinsic sensing, not what you see on the ECG. Looking at sort of the intervals of the earlier beats, they seem to follow the QRS more than the prior paced expected beat.
So we have, as you say, atrial fibrillation. We have we know that it is a biventricular pacing, but the QRS complexes are not biventricular pacing. So again, is it a programming problem or a lead problem? And we have those spontaneously conducted white QRS complexes with QRS with a pacing spike on the middle of them that is probably not pacemaker malfunction, but an attempt to synchronize. Those things will not be seen in a regular DDD pacemaker because then we want to minimize pacing. 61-year-old female with bicuspid aortic valve who underwent AVR 2 days earlier. What can we say?
We see electronic ventricular pacemaker, like ventricles are paced, I see correctly, and there are very low amplitude visible P waves. Some of them are closer, so some of them has the more proper AV delay, but I think some of them are really has a long AV delay. But for example, in lead V1, we have a small amplitude P wave before on the second beat. We have a very little P wave, but when we check the third beat, the AV delay is almost 300 milliseconds. It's quite longer, and then I can't see, or it's hidden in the T wave, but there is no P wave. So I think there is an AV block, I think, and the pace is properly working and pacing the ventricle in a constant rate. But I think there is an AV block here.
So remember, my view is not an electrophysiologist. I'm talking about the ECG interpretation. This is a computer, electronic ventricular pacemaker. So we should add sinus rhythm with complete AV block and ventricular pacing. And now speculation, since the pacing spikes are so big, it's probably a temporary pacing, as I said, 2 days earlier. So probably it's not a permanent pacemaker, it's unipolar leads. But we need to comment on the AV block that is not abnormal for pacemaker. Any more comment? Okay, 74-year-old male with ischemic cardiomyopathy, EF20, St. Jude pacemaker, who presented with non-STEMI and underwent CABG for left main 70% stenosis and RCA. What do we see?
So I think probably this patient has epicardial pacing leads.
In addition to his pacemaker, yes.
In addition to a pacemaker, this patient has a pacemaker, sorry. So you see the pacing leads. You know, looking at the the relationship with the P wave and QRXs, you know, they don't seem to be constant. You don't know the sinus rate for sure, but you know, it appears like it's you know, a little slower than the 60 beats per minute. We know that the patient underwent surgery and they instrumented. Most likely the bipolar spikes or the smaller spikes. You know, it seems like there is maybe some sensing and some output problems. And so just clinically putting it together, the situation, it's probably a temporary pacemaker. As you mentioned, with the unipolar large pacing spikes was put in due to failure to output or failure to sense from the RV lead. And occasionally you see the spikes are outside of the refractory period of the tissue. You see sort of these left bundaloid morphologies, almost RNT in a way.
Yeah, so you are right that, I mean, I have not seen a lot, and I don't know the clinical decision why they put a temporary pacemaker on top of his pacemaker. Maybe the surgeon put it because this is a routine after surgery. I saw one similar ECG, and it was gastric patient with a patient with diabetic gastropathy. And so there were those weird pacing on top of the pacemaker, and I published it somewhere many years ago. But this is two pacemaker in a patient. 3. So, and this is the temporary pacemaker leads and the regular pacemaker. So 81-year-old male with non-ischemic cardiomyopathy, low EF, Medtronic Biventricular ICD, and what do we see here? Professor Gutiérrez?
Very interesting. Wide complex tachycardia, regular wide complex tachycardia. The morphology suggests a supraventricular mechanism. We cannot see the last 3 precordial leads, but it looks like a typical left bundle branch block morphology. So we can suspect that this fast rhythm could be supraventricular. And the device is starting a ATP sequence, as we can see, but we don't know if this specific ATP run was effective. And of course, this tachycardia is detected as ventricular, and the device is applying multiple shocks.
Okay. Any more comments? You're right. And I don't know what happened with the patient. I just saw the ECG. what do we see here? 49-year-old male with cardiac sarcoidosis, non-ischemic cardiomyopathy, biventricular ICD, Medtronic, admitted after syncope during MVO2 stress. Any volunteer? Adrian, you are here. Good morning.
Hello, how's it going? Can you hear me?
Yeah, you tell me how it's going.
Very cold. We are at -12 with a feeling of -27.
Wow.
So if someone is too warm, we can share some cold here.
Any comments here? So I think we can say that we see P wave. And there is something on the P wave here that might be atrial pacing, and it should not be there after the atrial activity, spontaneous atrial activity started. So this is probably atrial lead malfunction, and this is a ventricular pacing, and this is a PVC, and there is probably spontaneous P wave on top of it, after it, and another PVC or something that started. Here is a PVC that was not sensed by the atrial lead probably, and it paced here. Do you agree?
So the atrial lead nonsense in the PVC is something that cannot be considered an abnormality. What I agree with you is this is ventricular capture. You don't see my arrow, of course, but after the first PVC where there is an atrial spike, so then it comes 1, 2, 3, 4, 5 beats that are ventricularly paced, one ventricular beat that is properly sensed with retrograde conduction. So in the ventricular side, it seems that there's no problems. The problem is why the atrial lead is firing and not sensing properly the P wave, and that could be, as you mentioned, an undersensing of the atrial lead. That's one of the options, right?
Yeah.
I don't think that there is dislodgement because the ventricular lead is capturing properly, and the atrial lead never captures the ventricle. So it is highly likely I could confirm with an X-ray that each lead is in each side, but then maybe that's something that we can fix with programming.
So no problem with the lead. So then you are going back to, is it an artifact? Always, I simply don't know. This is when when you are in your EP clinic or seeing the patient and you have all the tools in the world, you can see the ECG and have the interrogation and compare the things. Sometime I see an ECG, I'm going to the electronic medical record, I don't see anything. Or I'm getting partial answer. So not everything I know, but this should raise the issue of atrial lead malfunction. That was not corroborated by the EP study, by the pacemaker study. So what do we see here? 59-year-old male, chronic anticoagulation for DVT-PE with Medtronic pacemaker for symptomatic bradycardia, present with stroke. So we are starting with the atrial rhythm. What is the atrial rhythm? P, 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 P.
It's called atrial tachycardia, I think.
Atrial tachycardia or slow atrial flutter, I don't know. And somewhere here, there is atrial pacing, and here, which I don't know what happened, but it is, don't miss the atrial rhythm when you are reading pacemaker ECGs. So we are about to, let's do this one last. 50-year-old female with non-ischemic cardiomyopathy, EF of 20, paroxysmal atrial fibrillation, pulmonary hypertension, Boston Scientific, biventricular ICD in place since 2009, admitted for syncope. ICD interrogation showed VT, attempt ATP, subsequent VF with successful defibrillation. What do we see here?
I think you have to look to see to the very before the last beat to have a clue on what could be going on here. We have Bob Hamilton in the audience. Bob, if you want to provide some input, please unmute yourself and jump in whenever you want. Is that possible in this platform?
Yeah. Henry? Are you awake, Henry?
So there are two spikes in every beat almost, but so this is biventricular, but as you said, there is a clue before the last beat. So there are two spikes here again, but the first spike is making the QRS complex, and then another spike is here. So, and also as the first one is atrial spike maybe, we can see that it's also occurs after the P waves on before the preceding beats. So may it be again a problem with the atrial lead. So it's
atrial lead dislodgement. Now,
yes,
the atrial lead is pacing the ventricle. And if you look carefully with a bit of imagination, you can see that there are two spikes after the QRS. This is a ventricular pacing. So this is sinus rhythm with PACs and biventricular pacing and atrial lead dislodgement. Now, as I said, in many cases, biventricular pacing does not result in narrow QRS because those patients are so sick to begin with that whatever you do you cannot narrow the QRS. Or if you're cynical, they didn't do enough. But
Yochai, can I make a contribution to your explanation? when we see two spikes, I was not sure if it was Iona, the one describing, but in the 1, 2, 3, 4, 5, 6, 7, 8, all that AV is 40 milliseconds. So that atrial lead is firing at any level of the tricuspid valve before the spike that depolarizes the QRS, but it's certainly not occurring fully in the ventricle because it's not depolarizing anything until the beat with the two spikes. But if you see the QRS depolarized by that beat, is completely different than the rest of the QRSs. And I suspect that this may be only right ventricular pacing, not biventricular pacing. If you see it's much wider in B5, okay? So this one seems to be a purely maybe apical pacing. So this is not only the atrial lead dislodged into the ventricle, and maybe this being the proarrhythmogenic mechanism, because as it did not sense any P wave, it fired on the ventricle. In this case, it's refractory, but there is also a problem with the LV lead that in this beat did not capture. This is why we have a completely different QRS in the double spike one. I know that the second spike is the atrium, because otherwise one could expect safety pacing if the first spike depolarizes the ventricle and the second one falls into refractory period of the ventricle. But this spike to spike interval is too wide for this to be safety pacing. So there's no other differential diagnosis than the second spike being the atrium. Do you buy that explanation? Or
yes.
so. I accept different opinions. I know nothing about the case.
Okay, I think we'll stop here. I have a few more, but I need to go to work also to make a living. So since there are a lot of cases like this, we can continue with similar format either in the official ICE meeting or in additional seminars. In this one, I concentrated mainly on atrial problem, but there are more complex that are related to the original pacemaker programming and some nuances between the different manufacturers. Okay.
Okay, Yochai, I want to thank you very much for your all efforts to organize and create this session. The session was really great, and I also want to thank the discussants, to Harry, to Oswaldo, and also to Ozge. And I hope to see you again in our April webinar. Our April webinar will be on ECG in inherited arrhythmia disorders. It will be part 2. Please stay safe and have a good day. Thank you very much.
Thank you. Thank you. Goodbye.
Thank you. Bye. Good morning.
Thank you. Goodbye.